Hello, this is Fernando Gomez Sancha, and this is the initial video of the Thulium fiber laser enucleation of the prostate series that I'm going to start posting. We are using the fiberdust Pro Thulium fiber laser from Quanta System, and I'm using the settings of 2 joules and 30 hertz with a 550 fiber. So it is going to be interesting because I have a very limited experience with this laser, and as always, and as you will probably be able to see if I keep posting videos with this laser, probably my use of the energy will improve over time, because I always think that it takes a while to get used to new settings and new forms of energy, and only by repetition and a lot of experience you can make the most of it. I'm very used to using a holmium laser. As you know, you have seen probably most of my videos have been posted with a holmium laser. So let's see how it goes. Of course, the surgical technique is going to be the same. You have seen that I have reproduced the steps of the initial white line demarcation. This is the entry into the plane in one side, and now we go to the other side. The first impression I got from this laser is that it is a little bit less, let's say, powerful to open the plane and to dissect, and you will see during the operation that I get a little bit anxious and I do a little bit of contact, because probably I am used to working at a higher speed, or expecting a little bit more result, let's say, more dissection from the current with the distance that I'm using. You know, during the operation I will be working a little bit closer, a little bit less close. In theory, we have to do, let's say, we should be using a no-touch technique for the majority of the procedure, although touching in certain circumstances is not a sin, you know, and I think the idea of not touching is nice because you let the energy do its job. But as I said, my first impression was that with these settings, 2 joules and 30 hertz, which is the maximum that this thulium fiber laser can give, we have a little bit less aggressive, let's say, dissection effect. Of course, the peak power of this laser is much lower than the holmium, and we can see that there's less punch, less dissection effect, and but of course that justifies my impatience, let's see, and the tendency to keep very, very close to the tissue, trying to maximize the effect. So that's now the development of the posterior line. You see, the hemostasis you can get with these lasers quite nice, I think. It is quite good hemostasis, and the cutting properties of the laser, I think, being a pulsed laser, a little bit less impressive than the continuous wave thulium that we were used to see. You see that I can do dissection, I can do cutting, but I'm keeping my fiber a little bit closer to the tissue. Even, you see, I don't usually do a lot of mechanical dissection, but there I was guessing, was checking, you know, that the plane was correct by a minimal dissection maneuver to check that the plane was correct. As I always say, this laser's hemostasis also obliterates the beautiful plane. So you don't keep seeing the beautiful plane, because even when you are in the beautiful plane, because the energy and the hemostasis is going to, let's say, stop you from seeing that beautiful quality. So we know that we are in the good plane. You can see that the tissue tends to detach very nicely. So we are in a nice capsular plane, but we will not be able to see the beautiful plane all the time, because the energy is going to coagulate it. You will see throughout the procedure that I feel a little bit less comfortable. Every time you change your laser or your settings, you're a little bit out of your comfort zone, and here probably I'm playing with the distance and the tissue characteristics. You see that if you get too close and if you stay a little bit longer than you should, maybe then there is a tendency to deepen a little bit into the capsule at this distance. So you see, it is a trial and error activity to try to find out how to make the most of the settings and the source of energy that you have chosen. Here I am deepening my white line, trying to make a deeper incision. I don't mind cutting a little bit into the enoma. This is the 12 o'clock mark that was not properly finished at 12 o'clock, and now I'm finishing it to have a nice reference. And that deepening is going to give us a little bit better access, so we can see the proper plane. And then of course we will try to ascend with the dissection, aiming towards 12 o'clock. But of course we want to mobilize the apex first. So here you see we do these up and down movements to try to mobilize the apex and then connect with the line of dissection that we had on the posterior aspect. So as you can see, the surgical steps and the technique is exactly the same. What I'm trying to find out here is what working distance and what speed of movement will give me a nice dissection. And this is looking quite good now. I mean, there's some opening of the plane. There's a smooth line that I can follow laterally. You see, trying to use maybe a little bit further distance. Here I'm coming back towards the most distal attachments to try to cut them before I continue the dissection more anteriorly, because we don't want to pull the sphincter with the shaft of the endoscope. So I tend to cut the apical attachments first, and then we continue trying to find the good plane and trying to follow the lines. When I was a boy, I saw with envy how some of my colleagues at school were very good at drawing, and I always felt that was an amazing thing to do. And so I take lessons for drawing, although I'm not very good. And I have to say that I find a lot of parallelisms between the drawing activity and the enucleation activity. So you see here, I always say that the fiber is like a pencil. With a pencil you can do different kinds of lines depending on how much pressure you put on the pencil, how you tilt it, how you move it. And these lines might end up doing a very nice drawing or not, but it's not the pencil that does the work. It is the artist, who has to decide how to use the pencil in a particular moment to render a beautiful drawing. So also, when I see these classes, they talk a lot about rhythmic lines and lines that are beautiful because they are done with rhythmic movement, and So it becomes a little bit philosophical. And here, in enucleation, I find that all these lines that I'm trying to draw, you see, now coming up and down, are extremely helpful to keep you in the good plane. So, because not always you can see, the plane until this is the right plane and this is the right. So the anatomy that you see endoscopically doesn't always tell you, what is plane, what is adenoma. But of course, we know how the anatomy looks like, more or less. We know what generic direction the lines should follow, and then we just have to draw these lines with the tip of the laser. And I have to say that these rhythmic lines and this movement of the scope, that tries to follow the line a little bit, sometimes the anatomy helps you, or because it tells you this is good. I mean, the line you're drawing is precisely the line that you should be drawing. But sometimes you have no clue, and then you have to rely on the line direction. You have to rely on the rhythmic lines that you're drawing, to continue with your dissection, hoping that this is the good plane. So not always anatomy tells us exactly what we need to know, but of course we mix what we see, or we take as much information as we can from what we see, and then of course we try to use what we know. I mean, the anticipation of how these lines go, and what we can imagine. Sometimes we are doing these lines, you see, trying to connect the lines from one side and the other, and trying to continue with the dissection. So here, this is now the development of the anterior plane. You can tell that we're progressing, nicely and relatively fast. And I'm trying to do this long movement from side to side to try to carry a regular line that will make our life much easier. When you have a regular line, with a regular depth, you have a much better understanding of the line and the plane. You have a very nice reference. So it's worth, committing to carry these beautiful long lines and do these wide movements rather than very short movements that will make less uniform lines, no? So this is like your GPS for the operation. You need to be able to recognize the lines. Here you see that I'm doing a little bit more contact. When we do contact, there's obviously more penetration, but I think when I feel that the plane is not developing at the speed that I think it should go, maybe I am getting anxious and I'm, getting closer to the tissue. Maybe in order to use this laser, you should be, how do you say that, more patient and do more passes, letting the energy progress slowlier. And here I am conditioned by the desire to advance in the operation, as I work. So you see, this is the video of an let's say expert surgeon on enucleation, using a source of energy where the experience is not so abundant. I know the anatomy, I know where I have to go, I know what I have to do, I know my limits, but you see, maybe the technique that I'm using is not perfectly adapted to the energy I'm using. Maybe I should aim, and now that I watch the video myself, because it's always different to do an operation and to remember the operation, and then when you watch the video you start realizing things that you didn't see during the operation. So this is an exercise that is very, very nice, very humbling, and that I recommend to everybody. Record your operations and have a look at them afterwards, because you will see things that you didn't see before. Here, for example, in this moment, when we get to this point where we see the bladder neck and we're trying to, cut it open, I think this is where the no-touch technique is not so relevant, because actually with the no-touch what you're trying to do is not perforating the capsule, but here, if you think about it, we want to perforate because we want to open the bladder neck, and that's why I tend to use a little bit more contact or near contact lacing near the bladder neck. You see that I always follow lines. You see these lines, these rhythmic lines that I'm drawing from one point to another point, trying to continue the dissection, are very important, and they help me keep the orientation. That's the bladder neck. Now coming closer to the UO, but there's still quite a good distance, so we're happy. And here also the same principles that I have discussed over the other videos should be applying. Like, of course, we want to keep close to the adenoma now, because you see the fiber is becoming more perpendicular to the tissue. And if you do a small mistake, if you get too close to the tissue, especially when we are near the capsule, or even in a relatively deep capsular plane, maybe deepening a little bit, or maybe just because the capsule is thinner at this region, if you do touch, if you do contact and you stay there, you might do a little hole. And as I always say, a little hole is okay. You don't want to make them bigger. But you see, this is the struggle, and this is how interesting it is that you know the anatomy, but when you change the tool, when you change the effect of the energy in relation to the tissue, and you're not very familiar with it, then things look a little bit different. It's not so bad. You see that I always look for a capsular plane, and I don't really care if the plane is the beautiful, the mythical plane that many people look for. I just I'm happy if I am in the interface of the adenoma and capsule, or a little bit deeper. I wouldn't mind, as long as we don't perforate this peripheral zone deeply. So here you see I'm having a little bit, say, trouble keeping a beautiful line and progressing as I would normally do with the holmium. You see that often it's a more irregular posterior plane in this case, maybe, as I said, due to the fact that I'm not, this is not the laser that I use all the time, every day, but a laser which with I have much less experience. See, hemostasis is very good, and I think that's a plus for a lot of people. But again, I would think that the fact that this laser doesn't necessarily open the plane, help you stay in the plane the way that a holmium laser would do, and the fact that, you see, the cutting is not so good, I would say, the cutting, but of course it cuts, and when you cut into the tissue, you might be cutting in a region or an area that is not necessarily the good plane. Or what I'm trying to say is that with a holmium laser, the peak power is much more evident, and the opening of the plane, due to the mechanical effect of these little bubbles, these little explosions happening in the tip of the fiber, help you keep in the right plane many times, a little bit more than this laser. This laser opens the plane a little bit, but it also cuts, and this cutting effect sometimes can take you a little bit away from your plane. I think that, as we said before, you don't necessarily see the plane all the time to know that you are in a good depth, because if you follow these lines and you follow the dissection in the good depth, well, you won't get lost. Probably in my case also the experience helps, me to know if I am in a good depth or not, but I reckon probably this laser would be a little bit more difficult to use from someone who is learning or starting at the beginning. And it doesn't have the benefit of holmium in the sense that holmium tends to keep you more in the plane than this laser. Okay, so the dissection effect is less prone to keep you in the anatomical plane, let's say. The cutting is okay. It's not the best cutting in the world. I think the continuous wave lasers used to cut better. But still, it's a little bit tricky. But hemostasis is perfect. I think it's very good. And that I understand that many people like this laser to work with it. I find it intriguing. Of course, I always enjoy trying new stuff and trying to understand and trying to improve. And I think it is a good thing to be able to reflect on different effects on tissue and different possibilities. No, the anatomy is the same. The source of energy is a little bit different. My general feeling after this case was that it was a little bit more difficult to dissect the plane, a little bit slower maybe. Also here we are working at 60 watts, whereas with the holmium I would work at 100 watts. Lately I'm trying 120 with holmium. Also it's interesting, I use two different consoles. We have one Quanta holmium laser in Bulgaria, another in Madrid. The one in Madrid is a little bit older and probably has more cases. And I have the feeling that probably our laser in Madrid is a little bit slower. The effect is a little bit less patent than the newer laser. Maybe there is some, deterioration of the quality of the beam when you use the laser for a long time. The crystals are worn out. I don't know. This is something I have to discuss with the factory to see how it works. And here you see I'm trying to follow the line, trying to stay within the plane, to avoid perforations and working the difficult angles. This posterior line now coming to connect to the lateral line near the bladder neck. So see, there are certain moments in the operation where you have to continue. It's a little bit more tricky sometimes. I wouldn't get stuck there, if some area looks a little bit difficult and you get stuck, then go somewhere else and continue the dissection, continue the mobilization. And then after some time you will find that going back to this same spot for some reason is easier now after having mobilized more of the adenoma. You have better access, better mobility, so don't get stuck in the difficult places. Here I was progressing, so I thought maybe I can continue, but as a general rule, when I find it very difficult to do something, I go somewhere else, and then I revisit that difficult area later on when I have better chances to have a good exposure, good mobilization of the region. Here, of course, I'm trying to keep the fiber close to the adenoma, but of course I don't want to leave BPH tissue, but you see that it's getting a little bit more difficult to have a proper line. It might be my impatience, as I said, because I want to move on. I'm used to a certain, let's say, rhythm in the operation, a certain pace, and maybe I'm not patient enough to try to use the laser a little bit more carefully and draw a little bit more careful lines. And here you can see that occasionally we're getting a little bit deep into the peripheral zone. So when that happens, I try to correct, keep the fiber up close to the adenoma. But of course, there is some, let's say, invasion in the capsule. In my experience, these little things are not too relevant. That it doesn't really change things very much. I don't experience more problems because there was a little area where, you know, the dissection was a little bit deeper than what we would want. So I'm quite relaxed and just continue to dissect. You see, in some areas we are capsular, in some areas we're probably inside the peripheral zone a little bit, but I try to continue my lines, try to keep the fiber closer to the adenoma, trying to keep the energy a little bit away from the capsule so that we avoid, you know, major perforations. And now there's much better mobility. I'm trying to see how much tissue left there is, because soon I think we can start pushing, and that's a little push, trying to mobilize the adenoma into the bladder. It is going, but not so easily. And I discovered some little vessels there. There's a lorry coming in my street, you know, announcing something like, these guys are making a lot of noise in the street. Okay, so there we are, trying to finalize the posterior aspect at 6 o'clock. As always, you see these lines that come up and down, you know, from side to side, always trying to do a smooth movement. But of course, unless you get the distance right, you know, you might, or how do I say this, the margin between deepening a little bit too much or not progressing fast enough, you know, make me a little bit impatient. And so, but there it is. I think the operation went well. It's nearly finished. Now I'm going to try, and that's the tilting of the prostate into the bladder. And now we have some 6 o'clock attachment. I'm going to try to detach it, doing this smiling incision from side to side, trying to see if I can deliver the adenoma into the bladder. So interestingly, you know, the speed of the operation is not so much related to how fast you go. I mean, if you rush it a lot, you think you might go faster, but often times I think it is more a function of how continuously you can work. So you don't need to go very fast, you just need to continuously work. So when you continuously work like that, and that's the sphincter mucosa, it's looking very good. There's a little millimetric flap on the right side. That doesn't bother me at all. I think that's a minimal. But the whole mucosa of the sphincter was covering the sphincter, so I'm quite happy. I'm sure this patient will have excellent continence from the very beginning. And that's an attempt to coagulate, also using the same setting. I think on the other pedal I had a continuous wave Thulium setting with 1 joule and 30 hertz, but I could see that this wavelength, keeping the distance, and these settings keeping the right distance, allowed me to get a very nice coagulation. You see that there's some areas where there's a little bit of depth near, you know, near capsular perforation without much trouble, I think, and not so. Of course, when you do HoLEP or enucleation, you get used to seeing these things, and initially you might be tempted to panic, you know, because you saw a little bit of fat. But with experience, I think you don't worry so much, and especially when, you know, the procedure has been reasonably fast. It was less than 30 minutes to do the enucleation in this case. And now what I'm trying to do is to keep the hemostasis. Also, I always think that this is the view of a very distended fossa. So when you put a catheter and you collapse this fossa, all these, indentations in the peripheral zone, all these areas where there is a little bit more penetration will collapse, and I think the capsule will not be distended like this to this level, when the patient feels the bladder and needs to void. So I think all these edges of the small near perforation areas will get together and stick together very, very fast, and that's why we don't see a clinically relevant problem, when you go deeper. So I think it was not bad for a first, let's say, initial experience with Thulium, but you can see that my mastery of this wavelength and settings is not still mature. So I hope to be able to show you other videos in the future where we can see how this evolves when I get a little bit more experience, and if I could run the beautiful lines that I usually do with holmium. As you can see, we have tried holmium, we have tried Moses, we have tried virtual basket, we have tried other pulsed thulium lasers, not thulium fiber, and the anatomy is the same. The steps of the operation are the same. The surgical principles that I discuss, like distance, running these long lines, aiming properly, are the same. But of course, changing the wavelength or the settings often makes you be less, less precise, and it affects a little bit the beauty of what you're doing. I think beauty in surgery comes when there is a lot of experience, and that's why I'm a little bit puzzled when people use a laser and they make a verdict as if they knew, perfectly what is the difference between the laser they just have tried and the one that they had before. I think you cannot tell in one or two operations. There's too much variability in prostates and quality of the planes and everything to be able to judge so soon. I think we have to do, tens and hundreds of procedures to really understand the subtleties of how to use an energy source and the settings that you choose and how to make the most of them. So it doesn't seem to me as a simple issue. And this is a morcellation. So as always, I try to keep the morcellator blade a little bit inside, around the middle, the center of the screen. The tip of the morcellator is at the center of the screen, so that the anterior part of the image is filled with adenoma. And then I have two corners on the sides of the blade where I can see the color. And if it's black, I know that I'm not near the bladder wall and I can still continue morcellating. So this is the Piranha morcellator from Richard Wolf, and it serves us very well. It is a very consistent morcellator and a little bit tricky to manipulate, but with experience and working in an experienced team, it is a very reliable morcellator. The rate of removal of tissue is very nice, and for the majority of prostates, it's a joy to work with it. Sometimes when we do monster prostates, we wish we could have another faster morcellator to remove more grams per minute, but I think it's one of the competitive morcellators in the market and probably better than most. So this is a nice experience. I have not been publishing too much lately because it takes a little while to prepare the videos, and and also because I felt that my job was mostly done in the sense that I have shared all my tips and tricks in the videos that I'm showing, and that more content would probably be just repetitive. But I'm working on trying to do some live cases transmissions. I'm trying to see if I can get the needed setup in my operating room so that I can do live sessions where people could join and ask questions and like that, to continue sharing my experience with enucleation. That many people tell me it's being very useful. So I'm happy to always try to share. And it's interesting, I think, to start exploring the thulium fiber. I will try to do cases every week and see if I can at least weekly post some video with thulium fiber, so we can get to know better how this laser works in different situations and different prostates and like that. I still, of course, think holmium is my favorite, but let's see if I can change my mind, or at least get to know better what are the strengths of thulium and holmium. I think we will still see a lot of technical developments, and I think companies are researching and trying to improve the quality of the instruments we use, trying to get to this holy grail of energy source that would give us the best of all worlds, like excellent anatomical dissection, a laser that has the quality of holmium in the sense that it gives us very good dissection of the plane, the peeling of the plane, while improving hemostasis. And I think with this, coming instruments, we will have better and better ability to do enucleation, and it will become even more democratic. I have to say that the interest worldwide in enucleation is huge. There's many people learning, wanting to learn, going to courses organized all over the world, and I think it's a good thing, because these are the happiest patients that I have ever seen after a BPH procedure. And having done enucleations for many years, I'm seeing patients after many years, and they feel good as the first day. So definitely worth learning to enucleate. Not as difficult as you might think, and I'm very proud to see that many people who came to visit me, to the courses we organize, or just visiting us in the hospital, are writing me and telling me, I'm so happy and I'm doing this difficult case, or I'm learning and I'm able to do HoLEP, and we're very happy as well. And we have a very low incontinence rate. So I can see that people are starting to reproduce this excellent approach, and there's more and more conscience that you should be trying to preserve the sphincter mucosa, and the early release probably helps in that respect. Although we have participated in a registry recently where the benefits of Bloc enucleation and early apical release and are not so evident, and I suspect that still there's a lot of differences in how I do this procedure and how other people try to reproduce it. It must be, the devil must be in the details, and if you do a Bloc and if you do early apical release and you're not getting good continence, immediate continence results, there might be some details on how you are approaching this, and the force you're doing when you operate, and how you protect the sphincter area during the dissection, that could influence these results. Okay, so This is now the end of the case, and I hope you enjoyed the video. Send me your comments. All the best. Bye bye.